Sorry for the inconvenience and sorry for this technical error. So we'll proceed with Dr. Mishal's the rest of his talk. Then we'll go for pediatrics module. So, Dr. Mishal, thank you.
So Majima, he did a physical or biomechanical study in a wrist and a neutral and extension. And if you see the forces here are distributed differently in a distal radius. So I will not go through this in deep, but let's assume this is a scaphoid fossa and the lunate fossa, okay? So these are the areas where affected during the fracture. What is the position of the wrist? And the forces goes in this direction and the break happens. So if you see in the lunate fossa, that's why the volar distal radius fracture are unstable than the dorsal one. Okay, so if you see this X-rays and you decide we can treat a distal radius non-operative by splinting, and you will get a good result. But what about this? Okay, so if you have a patient, young patient with this kind of fracture, I think most of us will treat him operatively, but what about a 70 years old or like say an 80 years old? It's a different situation. Always weigh the risk and benefit of the surgery. So if you have a patient with an ASA, let's say 1, and he's an 80, I guess the risk of surgery are low, so you go with an operative treatment. But if you have an ASA 3 and 4, that means the patient is high risk with high comorbidity, and most of us will treat this patient non-operative. And I'll show you in a while, like most of the studies show us that even with minimal displacement or some changes in the mechanics of distal radius, still the patient has a good outcome. So this is a randomized controlled trial. Compare the non-operative with an volar plate or operative treatment, and these patients are equal at 5 years point, but the operative are a good outcome in early time. So at the point of 5 years, both are the same. So the non-operative treatment may be the preferred method for treatment of old age group. But this is, we have to take it in consideration. As I said, the comorbidities, how the patient, the ASA of the patient, and always discuss the option of operative and non-operative with these kind of age group. And this is another study shows that the DASH score for the operative are high and good, but you will be surprised with this kind of X-ray, with some loss of height, radial height, and inclination. Patients are doing good. At the end, at a certain point, both of them are doing the same. But most of the trials in the literature, they have short over large sample size, and most of them, they conclude that these trials require like a more sample size to conclude which better non-operative or an operative. This is a bird's eye, I say, the bird's eye trial or a meta-analysis is published in Public Library of Science, and include a 31 randomized controlled trial. And in the treatment of distal radius, operative and non-operative, and I quote in the conclusion that surgical treatment of moderately displaced distal radius fracture in an elderly patient offer no clear benefit compared with a non-operative. treatment. So the plating procedure have become more common during the second millennium and involve higher cost and higher risk with the major complications. So these are my indication for a distal radius fracture. Is a volar displaced fracture, fracture dislocation, and a multiple fractures. So usually with a volar displacement, you treat it with a volar plating, and this is the most common approach now. All the trauma surgeon, hand surgeons, they use it, and there's some approaches with a distal volar approach. You can do it extended now, and you have a clear picture. So very rarely we use the dorsal approach nowadays. And fracture dislocations. With an osteoporotic patient, I use bridging plate, and it's act as an internal fixation. So Roche first published this kind of treatment in a JBJS 2005, and included 22 patients. And the fixation, you can add the fixation with some pins, K-wires. The range of motion in his study is not good, it's fair. 120 degrees with a wrist is a fair range of motion. But the duration of the plate being in a patient is not a predictor for the range of motion. So most of the studies, the longevity of the plate in the wrist is not a predictor for loss of range of motion. There is, of course, some downside for this treatment, and a soft tissue irritation like an APL. So this is a kind of fixation other than an X-fix, especially an X-fix with a patient, with old patients have some complication. And you can do this treatment by minimal invasive. You just do small to proximal and distal incision, just slide your plate, fix the screws, and you can keep it for like 3-4 months, then you take it out. And the multiple fracture, of course, if you have a patient with elbow or upper extremity like elbow, forearm, even the distal radius is very minimal displaced. I rather to go and fix it for rehabilitation purpose. So in conclusion, still we don't have a clear cut for the treatment outcome of the elderly patient. Always discussing the relevant evidence with your patient when you decide both sides, operative and non-operative, and the treatment of distal radius is still evolving. Thank you for your attention.
Thank you, Dr. Thank you, Dr. Mashal. So unfortunately we are late, so we'll skip the question part and we'll go ahead with the pediatric session. Thank you, Dr. Mashal.
No question? Good. It's clear.
So without further delay, we'll start the pediatric module with a dear friend and colleague of mine, Dr. Ali Saleh. He is a pediatric specialist, head of pediatric unit in Jahra and Razi Hospital, and Jabr Hospital. The talk will be about hip surveillance in CP patients.
ما في مو شغال بس بزغدك في هذه خلها موجود.
السلام عليكم. Hip surveillance and cerebral palsy. Cerebral palsy is a very common disease in our community. We start first by definition of the cerebral palsy. So it is a group of disorder that affect the movement, coordination. It is often caused by a damage or injury to the developing brain before the age of 2, Hypoxia is the leading cause. It is usually combined by disturbance of cognition, communication, or behavior, as well as epilepsy. Why the hip? And why do we need to focus to do surveillance on the hip? Hip displacement is the second most common deformity in cerebral palsy, second to the equinus. The overall incidence of hip displacement between 25 to 35%, and it's directly related to the gross motor functional classification scale. Hip dislocation is associated with pain, difficulty with personal care, poor sitting and walking tolerance. In this study, which was done on 67 children in Norwegian registry, they found that patients who have hip displacement migration and migration percentage more than 40% is associated with lower health-related quality of life. The gross motor functional score, for those who doesn't know it, it's five grade. The first being it describes the functional ability of a patient. Grade 1 is almost near normal, and grade 2, he can walk in, he needs assistance on uneven surfaces, whereas in grade 5, he's mostly dependent on the caregiver. And in this study, they can show that the relation between the grade of the gross motor functional score and the incidence of the hip displacement. So it's in scale 1, it's near 0, whereas in 90% of patients who are GMFC 5 will have hip displacement. Causes of hip displacement in cerebral palsy patients still not fully understood, but abnormal femoral geometry by increasing the femoral neck shaft angle and the femoral neck anteversion, absence or delay of weight bearing, muscle imbalance, and pelvic obliquity. And here we can see the relation between the scale or the grade of the gross motor functional score and the geometry of the femur. So in all patients, all human beings, in the infant, the femoral anteversion is between 35 to 40 and decrease down to 10 to 15, and once reach skeletal maturity. Whereas in cerebral palsy patients who are grade 4 or 5, at the age when they reach the skeletal maturity, it's still the same, around 40 to 45 degree femoral anteversion. And the neck shaft angle as well. And the normal population at the age of adulthood it will be about 125, whereas in cerebral palsy patients it's around 150 to 160. All these factors will contribute to the hip displacement. Hip surveillance. Why do we need the hip surveillance? Early displacement is silent in CP patients with no clinical symptoms, and it can progress rapidly. As you can see in the X-rays, the difference between these two X-rays is about 5 months, and it went from subluxation to dislocation. And the other thing is the gradual dislocation will affect the morphology of the acetabulum and the femoral head and cause cartilage damage and irreversible damage to the femoral head or capital femoral epiphysis. And here another example with the serial of X-ray has been taken 2 years apart, and the patient went from completely normal hip joint at the age of 5. 6 years later, he has bilateral hip dislocation. And we can appreciate here the changes that occur to the acetabulum and the capital femoral epiphysis by the gradual subluxation. This is the acetabulum. Here is the concavity, and by time, it's become the acetabulum index is increased and become more flat. And the capital femoral epiphysis as well, we can appreciate in this image. The medial part, once it's abutment on the lateral edge of the acetabulum, it's flattened out, and the lateral side by the capsule and the gluteus minimus and medius, it will be deformed. And in this study, they found the natural history of hip development or hip displacement in cerebral palsy patient. Patients who are grade 1 and grade 2, they have an increase in the chance of hip displacement by 1%, whereas grade 4 and 5, it's around 4 to 9% per year. So we can appreciate how rapidly the patient can deteriorate. So what is the definition of hip surveillance? Detection of early hip displacement by active screening. And with active screening, I mean frequent examination and radiograph. What are the indications of surveillance? Spasticity, delayed walking or inability to walk, concern of healthcare professional, or concern of a parent. And if we compare the harm and benefit of hip surveillance, and the benefit is significantly outweigh the harms. Why do we need it? Early management will reduce the rate of dislocation and will improve the healthcare, the health quality related life. And how do we do the hip surveillance? It is a team approach that involves the caregiver, the physiotherapist, and the orthopedic surgeon. Repeated physical examination at regular intervals, and a standardized pelvic X-ray. And this is an example. If we implemented the hip surveillance, we can treat patients like in the first image with the minor procedure. It is the gradual modulation of the capital femoral ellipses and changing from the coxa valgans to coxa vara. It's a minor procedure in addition to soft tissue release, and save him from more advanced, more major procedure like the VDRO and the stapleplasty or salvage procedure like pelvic support osteotomy. And in this study, the hip displacement, it was done over 1,650 children. They found that hip surveillance had reduced the prevalence of hip displacement by over half and dislocation by half in these children. It was done in Scotland. With the hip examination, it's divided into two parts. First, classify, so we need to classify the patient or categorize him into which gross motor function scales, and to assess. And with assessment, we assess the pain, we assess the hip abduction, inflection, and extension. And hip abduction less than 40%, 40 degree in extension is a warning sign. Hip flexion by Thomas test, femoral antivergin, and popliteal angle. Hip radiograph. We should have a standardized hip radiograph, and the most appropriate radiograph is taking an AB radiograph in a supine position. The pelvis is horizontal, and patella facing forward, and to neutral abduction, and the knee flex to compensate for the anterior pelvic tilt and the hyperlordosis. The migration percentage, for those who doesn't know it, it's measured in the AB radiograph. We measure the total width of the capital femoral epiphysis and divided by the amount of capital femoral epiphysis covered by the acetabulum, and times by 100. So 33% is the risk or the red flag for hip at risk for dislocation. Another angle, it's the acetabular index, which is normally it's below the 25, and hip and the neck shaft angle. And because cerebral palsy patients have increased antivergin, the best image to measure the hip antivergin is internal rotation between 20 to 30 degrees. The frequency. It's ideally initiated at the age of 2 years, when the CP patient is diagnosed. But if a patient was diagnosed earlier, or he has high suspicion, or the orthopedic has received a referral from concerned neurologist, you can start earlier. The interval or the frequency of the examination and radiograph depends on the age of the patient and the gross motor functional scale level. The more advanced, the higher level, the more frequency. It can be reduced, and once the migration percentage is less than 30% for 2 years, and with the stable migration percentages when the percentage is less than 10%, the change in the migration percentage is less than 10 in 1 year. Patients who are gross motor functional scale is 1 and 2 can be discharged between the age 5 and 8, whereas patients who are 3 to 5 and the migration percentage more than 30% and the with pelvic obliquity should be followed until the skeletal maturity or the age of 18. This is an example of a surveillance program from the American Academy of Cerebral Palsy. We can see in the grade 1 and grade 2, the frequency is every year, and grade 1 we did not do any radiograph. We depended more or only on the clinical examination. Whereas in grade 4 and 5, it was 6 monthly, and in each visit, the patient underwent X-ray and clinical examination. Why do we need to do it? We want to do, by applying the hip surveillance, we want to do more of preventive surgery, which are mostly simple minor procedure like soft tissue release and Botox injection, and to reduce the number of salvage procedure once we reach the dislocation. Growth modulation, it's one of the new techniques in dealing with cerebral palsy patients. In this study, they found out a reduction of neck shaft angle by mean of 13 years after 2 to 4 years, and reduction in the migration percentage by 10 years. And it's applicable in patients who have migration index less than 50%. And we can see here an example. This is the index procedure. This is 1 year after, and this is 3 years after. Summary, hip displacement occurs in 30% of 3B patients. Gross motor functional scale 4 and 5 and migration percentage more than 33% are a critical risk factor. Hip surveillance is effective and necessary. And for more information, you can visit one of these websites. Thank you.
Thank you, Dr. Ali. Any questions from the audience?
So now is the talk of Dr. Mohammed Shahab. He's a specialist pediatric orthopedic at Al-Razi and Al-Jahra Hospital. He has done his fellowship at McMaster Hospital.
Hello, everybody. So my talk today is about the management of recurrent clubfoot and residual clubfoot. But I would go through briefly about the disease itself and the management of primary clubfoot, so we would have a better understanding about the management of recurrent and residual clubfoot deformities. So it is the most common congenital musculoskeletal deformity. The prevalence is around 1 to 7 cases per 1,000 live births. Almost 50% of them are bilateral. Familial occurrences is in 25% of them. Luckily for us and for the patient, 80% of them are idiopathic. Others are associated with other conditions such as arthrogryposis and myelodysplasias, and usually these conditions have a severe type of deformity, usually much difficult to deal with, and usually they need more surgical intervention. There is another type which is emerging actually in the literature, and we don't have a good clue about it, which is what we call is atypical clubfoot. And we need further studies to understand the atypical clubfoot, since there is no association with any other conditions, but usually they come with a severe type of deformity and difficult to treat. Although it is mentioned in the books that the success rate of Ponseti serial casting, which is the gold standard treatment for clubfoot, as to be 90 to 95%, but in recent studies we noticed that the success rate is below that, and actually Ponseti himself was quoted that 11 to 48% of patients ended up with residual deformities and have tendency to relapse, especially in those cases who are associated with other conditions. So what do we know about clubfoot? So basically it's a group of complex multiple deformities that happens in multi-plane. And to summarize the major deformities that we have the synonymous cave, as in cavus for the midfoot, forefoot adduction, varus of the heel, and equinus of the ankle. And as you can see, there are a lot of structures that are involved in clubfoot, a lot of bony issues, joints, muscles, tendons, ligaments. All these structures are actually affected by clubfoot, and this gives us an idea about the complexity of clubfoot. There are different theories in trying to understand the pathoanatomy and pathophysiology of a clubfoot, whether it is a bony problem preceded with a soft tissue tightness, or a soft tissue tightness preceded by a bony problem. But generally speaking, if you look at this diagram in the superior view, you would notice that there is this angle 160 present the angle of the talar head with the body. Normally it's about 160 degrees. What happens in a clubfoot that usually there is a medialization of the talar head, which lead to talonavicular subluxation, and that's why you would be able to palpate the talar head during the examination of the lateral side of the foot, and this will cause lateralization of the body of the talus. On the sagittal plane, there is downward movement of the talar head, and it would be another type of subluxation of the talonaviculum and would cause equinus deformity in the talus. And as we know, the subtalar joint, which is consisting of the talus and calcaneus, are in a relationship. And usually what happens is that there is what we call a parallelization of the calcaneus and the talus in clubfoot, although in other foot conditions there is opposite to that. So what happens basically that the calcaneus follows the talus in an equinus movement and medialization of the anterior or the distal part. And in the coronal plane, you will have the rotation of the subtalar joint, which would cause the hindfoot varus. Usually we don't take images for clubfoot patients. It is diagnosed clinically, but here you can notice the parallelization of the talus and the calcaneus. I'll skip that. So, an assessment, there are different types of assessment for the clubfoot. The most common one is Pirani score, which is very much helpful for assessing the patient's pre-casting, during the cast, and post-casting. Before the introduction of Ponseti technique, the mainstay of treatment was surgical. And Ponseti technique involves serial casting, a weekly cast, then with the tenotomy of the Achilles tendon, and then with the boots and bars. So in order to understand the way the casting is done, actually before Ponseti, many surgeons tried serial casting but failed. And the issue mainly was that they were not addressing the cavus deformity, as you can see. You cannot see the mouse. Okay, so the cavus deformity, as you can see now in this picture, was not addressed properly. Clinically, you would, if you pronate the foot, it looks like it becomes straighter, but in reality, when I do pronation, like in this video, you'd notice that the deformity is aggravated. So the first step is to do a supination of the forefoot in order to align the forefoot with the midfoot and hindfoot. And the second step would be correcting the forefoot adduction and hindfoot varus with the fulcrum over the head of the talus, and you would achieve the correction of the deformity. After that, the tenotomy is done. Otherwise, if you attempt to do a dorsiflexion in a serial cast, the patient will end up with rocker bottom foot. Okay, dynamic supination. Is it a complication? Is it a sequelae of the disease? First of all, dynamic supination means that during the gait of the patient, you will notice that the forefoot goes into supination. So if the patient is standing and he has a forefoot supination, that's not a dynamic supination. And usually you will notice this during the gait analysis. Whether it is a complication or sequelae, there is a lot of debate about that. What is the pathoanatomy? Is it anatomical due to bony changes versus functional cause, due muscle imbalance, in which the peroneal weakness happens usually with these patients, which lead to overpull of the tibialis anterior, and that would cause the dynamic supination, which is most of the literatures would agree on that. So the management for such problem is introduced in 1940 with a surgical intervention, which would involve anterior tibialis transfer. There are a lot of debate whether to do a 2-incision versus a 3-incision, full versus a split tendon transfer. We don't have, unfortunately, clinical studies to have a good comparison. But in accordance to the pediatric foot North American study group, they advocate for 2 incisions and with a full tendon transfer. The only good article that I found was a cadaveric module, and they found out that all techniques are helpful in correcting the tibialis anterior, or dynamic supination. So what about the correction of cases with residual and recurrent clubfoot? There are a lot of options that can be used. The most important, and usually is done in all type of surgery, is the soft tissue release. And actually, before the introduction or successful introduction of Ponseti cast, the main treatment was posteromedial release in all cases, and usually it was done at early age. And if you remember the slide of the structures that involved in the clubfoot, you would imagine the amount of release that it was done, especially with the Cincinnati approach, which is a big skin incision. And usually these patients ended up with stiff foot with a lot of complications till the serial casting was introduced. But still we use the posterior or posteromedial release for recurrent and residual cases. So what about the role of recasting in case of recurrent or residual clubfoot? Actually, there are more studies emerging discussing the role of recasting, and some actually found good results even at the age of 9 years of age. So if it is a flexible or semi-flexible type of deformity, I would really advise for recasting first. Hopefully that would work. If not, it would definitely reduce the amount of soft tissue releases needed. There are different types of soft tissue release, the classic one, or the what we call a la carte or consecutive operation. Unfortunately, we still don't have any algorithm for that. It is surgeon-based. But most of these articles found out that there is improved muscle strength, less hindfoot varus, less subtalar stiffness, and better radiological results. In a different study in which they studied the plantar pressure using a pedograph, and the comparison was between the less invasive posterior release in comparison to the classic posteromedial release, in comparison to the non-operative patient. In surgically treated patient, there was an increase in contact area and contact time, and there was shift of the pressure to the lateral side in comparison to the non-operative patients. But when comparing the classic posteromedial release with less invasive posterior release, the kinematic pattern is more comparable to the non-operative patients, and the push-off weakness is less in less invasive type of surgery in comparison to the classic one. The other option is midfoot osteotomies, and one of the most surgeries are done in clubfoot, which is the lateral column shortening or cuboid decancellation, which is actually a closing wedge osteotomy of the cuboid. But still, sometimes some of the patients, specifically those with semi-rigid conditions, the correction won't be enough. So there is the double column osteotomy, in which we add the cuneiform or medial cuneiform opening wedge osteotomy in order to correct the bean-shaped foot, as you can see in the picture. But the downside of this procedure that if there is any supination or rotatory problem in the midfoot, we cannot address that. So the other option would be to add a transcuneiform osteotomy in order to have a better correction. Generally speaking, all the authors advise to do such surgeries above the age of 5 for cuneiform ossific center to be visualized in the image. This is a percutaneous transcuneiform osteotomy or trans-midfoot osteotomy using a Gigli saw. And this can be also used in combination with the frame, hexapods, Lazaroff, or any type of frames. And in this technique, we can do distraction and we can actually do lengthening for the foot, because usually in a unilateral club foot, you will find out that the affected foot is shorter than the other side. So that would be able to be done. On the other side, the three-dimensional correction is much easier with the frame, plus the gradual correction, which would lead to decrease chances of soft tissue injuries with correction of severe deformities. Hindfoot osteotomies, these both, which involves the calcaneal osteotomy or the talar neck, both of them are historical, especially the talus osteotomy has a high risk of AVN, so that would be a contraindicated. Hindfoot osteotomy or calcaneal osteotomy still can be utilized in severe cases, especially in those with adolescent cases that where we are not able to correct the hindfoot varus with only midfoot osteotomies. Equinus, some of the patients, they have severe equinal deformity. Even with the lengthening and soft tissue releases, we are not able to correct the equinus deformity. So we have two options in here, hemiepiphysiodesis or growth modulation with the anterior distal tibial epiphysis, and this is done only for skeletally immature patient. And according to this study, they found out that the mean correction is around 6 degrees. And the other option would be supramalleolar osteotomy. In supramalleolar osteotomy, we can also address the rotational issues and problems, which we cannot do in hemiepiphysiodesis. And this is also, the mainstay treatment for skeletally mature patient. But the downside that there is around like 30% recurrence rate, and patient eventually would need another surgery in the future. Salvage procedure, these are usually kept for very severe cases in which frames are not available, or for example in spina bifida where the risk of infection and wound closure is very high. At that point, the talectomy, especially with non-ambulatory patient, is one of the options that can be used. This is a case with the spina bifida non-walker, bilateral clubfoot, and we did talectomy in order for shoe fitting. Thank you.
Any questions? Thank you, Dr. Muhammad. Now is Dr. Abdullah Al-Addar who will talk to us about growth modulation for deformity correction. Dr. Abdullah, he is assistant professor and orthopedic surgeon and pediatrics at King Saud University Hospital at Riyadh.
Assalamu alaikum. Good afternoon, everyone. So my name is Abdullah Addar. I'm a pediatric orthopedic surgeon, limb deformity surgeon out of Riyadh. I'm very happy to be here in Kuwait with friends as well. My talk is on updates in growth modulation. First of all, a few basic science points. So the physis itself is comprised of 5 major areas. There's probably 2 things to note as it relates to surgical technique. Now, the stem cells and the physis are mainly near the epiphysis. That is the germinal zone and the perfluorative zone. If you ever do a permanent epiphysiodesis, you want to mainly target the area near the epiphysis. Ideally, you want to take the entire physis, but if you want to do a permanent epiphysiodesis, you really want to target the epiphyseal side. Now, the other thing is, you notice the periosteal artery, the zone of Ranvier, and the perichondral ring. If you're doing a temporary epiphysiodesis, you want to not injure the periosteal artery or the zone of Ranvier. So 2 points as it relates to the physeal anatomy. Now, the guided growth basically relies on the Hooter-Volkmann principle, in which mechanical force influences longitudinal growth. If you compress the physis, which we try to do through a screw or via an extraphyseal plate, you want to compress it, inhibit growth. And if you want to distract the physis, such as in chondrodiastasis, then you can actually accelerate growth as well. Now, it's important to note that there's two main types. There's permanent or temporary epiphysiodesis. And permanent epiphysiodesis, you need to be very accurate in your predictions. It's more suitable for adolescents, and it's mainly for length equalization in Shapiro type 1. Now, temporary epiphysiodesis is more flexible, as it's reversible. You can use it in a younger age group. It's mainly used for angular correction. However, you can also use it in LLD and Shapiro type 3, 4, and 5. Now, most types of LLD, a physeal injury or congenital deformities, it's typically type 1. So there's a linear, in a sense, a linear slope or a linear pattern. So you can predict it. For everything you do, a multiplier app, a Paley app is really type 1. So in these cases are the only cases that you can actually do a permanent epiphysiodesis. If you have a type 3, 4, or 5, especially in hemihypertrophy or hemiatrophy, your predictions are not going to be accurate. It's up and down. So in those cases, if you have an LLD, you want to use a temporary epiphysiodesis. So it's very important to note these differences. Now, in terms of the implants, you can either use tension band plating, which is extraperiosteal, extraphyseal, or you can use transepiphyseal screws. Now we know that transepiphyseal screws are actually faster than plates, especially in adolescents with coronal plane deformities. And it's better for femurs than compared to tibias. Historically, there were staples that were weak and they bent or broken, so we don't use them anymore in a sense. So this is a study comparing essentially transphyseal screws with plates, and we found that transphyseal screws are actually faster than plates. So the practical implication of this, if you have a patient in his adolescence with a coronal plane deformity, you want to use a transphyseal screw as compared to plates. Okay, so talking about hip-guided growth, and then we'll go on to the knee, and then finally foot and ankle. So I think Dr. Ali mentioned this study previously. So if you have a patient with CP, and you're especially in the preventive stage with a high migration index, you can actually combine soft tissue releases with guided growth. And they found that basically combining them decreased the recurrence rate from 39 to 5%. This is an example of the cases where you had the high migration index, in the high 50s, 60s, and then with guided growth and soft tissue releases, it drops down to the 30s, and you can prevent a varus osteotomy. Now, the other indication is also coxa valga with DDH with a type 2 AVN. You can also use a proximal femur screw as compared to varus osteotomy, and you can actually control the proximal femur deformity. Now, the major advantage, obviously, of this is that, with coxa vara, you have a detensioning of the abductors and weakness and limping, which will take a long time, whereas if you use proximal femur guided growth, you can actually, the muscle has time to adapt to it, which is quite beneficial for the patient. Now, does the screw position matter if you do a proximal femur guided growth? It does. So if you're more medial, the more medial you are, you have a faster correction, a more powerful correction. However, the proximal femur will grow off of the screw. So you might need to do a revision surgery for that. However, if you're more in the middle, in a sense, it will take longer to correct. However, the screw will stay longer. So if you have an older patient, you want to be more medial. If you have a younger patient, you can try to be in the middle third. Okay, so in summary, if you have a patient with a CP with progressive migration, or if you have a patient with type 2 AVN and DDH with coxa valga, you can use a proximal femur epiphysiodesis. So Blount's disease. So I'm going to spend a bit of time on Blount's disease, and it is controversial in a sense, do we use guided growth or not? For part of the reason, and you have many factors in Blount's disease. Is this early or late onset Blount's disease? What implant are you using? What's the severity and how do you measure severity, okay? And then what about the other deformities other than the tibia? What about the femoral deformity? What about the rotation, the procurvatum, and the LLD, okay? And then how do you define failure? Is it a broken implant or is it under correction, and so on? So we'll go through a few studies just to try to clarify things. So in terms of a broken implant, we understand now that 12% of patients in Blount's disease in general have broken implants. The failure is typically a year and a half after, and mainly for the metaphyseal screws. The two main factors are an increased BMI. So in the group with a higher BMI, the breaking was higher as compared to patients with a lower BMI. The other thing is that a severe varus deformity, defined as a zone 4 mechanical axis deviation, also had a higher risk of breakage. And then if you have an older patient above 8 and you use a 3.5 instead of a 4.5 screw, you have a high risk of failure. Titanium versus stainless steel, there's really no difference, and whether you use 4 or 2 screws, paradoxically, 4-screw implants are higher, and that's probably because of a selection bias, that patients are more severe. Okay? Now the femoral deformity. So if you have a younger patient, it's most likely that the tibial correction alone will help normalize the femur. As in this study here, where 73% corrected the femur, whereas if you have late onset, you should ideally do both the tibia and the femur to correct the deformity. So these are all, the prior studies were all single-center studies trying to identify, factors relating to the success of guided growth in Blount's disease. Now, there's a large group in the U.S. that did multi-center studies studying early and late onset Blount's and seeing if guided growth will be successful. So in the first study, early onset Blount's disease was defined under 7, and they found that successful correction was about in 53% of cases. Now, the predictors of success, if you had the mild deformity, so the mechanical axis in zone 1 or 2, and the weight is under 70 kilograms, okay? If the MAD is higher, so 80 millimeters above, all of them failed, okay? So those are the two things. So if you have a milder deformity, a patient with less weight, it's more likely to succeed. Now, with late onset tibia vera, the same group studied them. This is defined as 8 years plus. The success was almost the same, around 50%, and the failure predictors were pretty much similar. If you have a higher weight, if you have an older patient, obviously, and if you have a more severe deformity, you would have failure of guided growth. So in summary, if you want to use guided growth of Blount's disease, you should do it with lesser degrees of deformity, defined as an MAD of 400 millimeters or less. A patient with lesser weights will also more likely to be successful. The femoral deformity will compensate if the patient is young. However, if it's late onset, it will unlikely be successful. Okay, so sagittal plane correction with guided growth. So you can use essentially guided growth for sagittal plane corrections in the knee, whether it's for fixed flexion deformity or recurvatum of the femur of the tibia. And this first study is by Dr. Marwan, where they reviewed basically guided growth in CP, arthrogryposis, and other conditions. And you can use whether plates or screws. Now we prefer screws because it's less painful compared to plates. And these are just images of examples of cases. So this is probably the most common technique. So anterior distal femur hemiphysiodesis. Typically, if you have an ambulatory CP patient with 2 years of growth left and under 30 degrees of correction, the technique is quite, and you have to know the technique very well. Where do you put the screws? The anterior half. You don't want to be very anterior and you penetrate the joint, so just the anterior half. And you want to put retrograde pins, and then you drill and insert the screws antegrade. Okay, trying to do everything antegrade will be very difficult, so this is a nice trick to do as well. The average age is about 12 years, and the other thing is that if there's an extensor lag, the guided growth will not correct it, so you need to do a patellar tendon shortening with it as well. Okay, now in OI, we understand that doing guided growth now is actually quite helpful, especially in milder forms of OI. Typically in OI, we don't want to use plates because of the stress riser and periprosthetic fractures. However, now we understand that using guided growth plates in OI does help correct the deformity very nicely. So you can see here that all the, in this study, all the joint line angles were corrected. None of them had a periprosthetic fracture. The only complication was in a single patient where they had a screw back out. And again, this is not meant for severe deformities, just mild deformities. Okay, so these are just examples where, again, you can see it's a mild deformity. Nevertheless, guided growth does help in correcting the deformity. Okay. So in the leg and ankle, you can use it for anterolateral bowing, you can use it for posteromedial bowing, you can use it also for ankle valgus, such as an MHE, and an ankle equinus and calcaneus. Now, distal tibia guided growth for anterolateral bowing, this is really a game changer in pediatric orthopedics. Classically, anterolateral bowing was treated with it's still treated now in severe cases with a cross-union procedure. You cut the femur, cut the tibia, replace the bone defect, and then do a cross-union. But now we understand that if you catch these patients early, especially in milder forms, and you place a guided growth plate, a simple day surgery, you can actually correct the deformity. The hamartoma itself also goes away with time, and you can control the patient very well with this. And this is just showing basically a 9-year progression of how this procedure works. Now, so in the foot with juvenile hallux valgus, another study did Dr. Marwan on juvenile hallux valgus, placing a first metatarsal base screw. Now we found that there was minimal correction with this and about 20% needed revision. However, we do believe there's two benefits. One, if you do an acute osteotomy, it might prevent or decrease the chances of recurrence, or just placing it will make the subsequent surgery once they reach skeletal maturity easier. Instead of having a large IMA, DMA, large hallux valgus angle, you can probably downgrade the patient to a lesser osteotomy with that. So complications. So there's not a lot of talk about guided growth complications, but I think it's very important to understand. One is obviously you have correction when the prediction errors in angular deformity, not completely corrected or overcorrected. In LLD, you might have a difference depending on our prediction. Rebound phenomena, especially with Blount's disease, we don't consider it a complication. It's rather part of the natural history of the disease itself. Implant failure, especially in Blount's disease, as we mentioned prior. And then if you use a transphyseal screw in the proximal tibia, they are prone to getting tibial valgus. So you have to know exactly where to put the screw in. Screw-related pain occurs in 30%, and then you can also have a physeal injury if you're doing a temporary physedesis and you don't abide by good surgical technique and principles. Now the final thing is about the future. Now these are basic science, and there's a single clinical study on this, which is the use of rotational guided growth, essentially, to correct femoral anteversion, retroversion, and tibial intorsion, extorsion as well. There's a single clinical study with there is some correction, but it's not really clear is it due to natural history or not. However, the principle is still there. So the idea is you put opposing wires with screws on opposite sides of the growth plate, which will correct it. That's it pretty much. Thank you.
Thank you, Dr. Abdullah. Any questions? Yes, Dr. Hattat.
If there's no ossification of the epiphysis. Yeah.
Still the mechanism of 8-plate correction will work? He will apply it or not?
Yeah, so I think another way to ask your question is if you have a very young patient, right, basically.
Yeah, usually,
Yeah, most likely patient, even at a young age, you will have ossification in the epiphysis.
This is not, usually there is no ossification, but in some cases, with a multiple congenital deformities, sometimes you will find this. There is no ossification. I had a patient like this.
Yeah.
With genovalgum and recurrent patella dislocation and congenital patella dislocation,
Yeah.
I want to correct first the genovalgum,
Yeah.
and then I will address the patella dislocation. Then the question will come: how you will correct the genovalgum using the mechanism of 8-plate in absence of ossification of the lower femoral epiphysis? Thank you.
Yeah, I think I've never faced a case like this before, to be honest. But what I can tell you from what I've seen is that in Blount, so for me, the minimum. It depends on the diagnosis, right? So guided growth for anterolateral bowing of the tibia at 2 years of age, I would do it, okay? In your case, if there's no epiphysis, if I can get good compression, because the principle is compression. So if you compress the growth plate, it theoretically should correct, and you don't have, and is there a downside to using it? And in your situation, if you apply a plate, it might not work, but it could work, right? Is there a harm in doing it? You know what I'm saying? The question is, can you get compression across the growth plate?
Yeah.
Yeah.
Okay.
So if you could, then it would work, and it's a minor procedure, I would say. But I can't predict in your case what's going to happen. Yeah.
Thank you.
Yeah.
Yes, Dr. Muhammad.
For the study that you presented for the rotational correction, like using the growth modulation, the age, at which age they started doing that?
So at a very young age, actually. So I think 4 or 5. So there's a lot of critique about this study that could be just natural history, and that's why I just presented it as
for the future.
Yeah, yeah. It's just there's a lot of critique on it. Yeah, absolutely.
Thank you, Abdullah. Question about the ossification of the epiphysis. I'm not sure. I've done one case in my fellowship where we actually did an arthrogram to visualize the epiphysis intraoperatively. Then we decided where to put our 8-plate, actually. This might be a helpful way of doing that.
Yeah.
All right?
I think that's a good point. Yani, for me, I can tell you is, yani, for the problem, yani, there's two issues. One, the principle is you want to get compression. If you can get compression, I think it's going to work. Regardless so I can with an epiphysis, with an ossified epiphysis or not. The second issue is if you do it at a young age, especially around the knee, will you get an intra-articular deformity because of guided growth, such as a pagoda tibia? That's another consideration in a very young patient. So, yani, in a young blount patient with severe deformity, I would probably try, depending on how severe it is. Yeah.
Yeah, I would totally agree with Dr. Abdullah and Dr. Yusuf. And also there is other option. You use a screw. And I remember that there was a study, a very small study, using screw with arthrogram.
Yeah, I think it's a reasonable concept to use a screw.
So, Dr. Abdullah, I'm going to ask you to proceed with your second talk regarding pediatric tiptoeing.
Okay. Okay, so this is more of a case presentation than a discussion. It's just was an interesting case. So this is a 9-year-old male with GMFCS2, spastic CP, no prior treatment, whether surgery or medications, and presented with an equine skin. So he's doing quite well until COVID hit. Then when COVID hit, he was lost to physiotherapy and just started to become much worse. So on examination, he's walking on his tiptoes really on the metatarsal heads, about 60 degrees of plantar flexion. The unique thing about this, it wasn't an equinovarus, it was really a pure equinus deformity with cavus. So it was an equinocavus or a double, some people call this a double equinus deformity. There was also pronation of the forefoot. He had a weak tibialis anterior, his peroneus longus was very tight, and the Silver skull test, we found that he was, it wasn't really clear to me, it was definitely Achilles plus gastroc, but because it was such severe, it wasn't clear, should we do gastroc or should we do Achilles? His hips were normal essentially, his popliteal angles were 45. And this is with the patient sitting down. We can see that there's the equinus, you see the cavus is quite severe, and you can see on this side the peroneus brevis was quite tight as well for the patient. So we had a lot of, another picture just before surgery, so you see the metatarsal heads quite tight, the plantar fascia under the skin, and you see the hind foot in this case was in slight valgus as well. So this is called a double equinus or equinocavus deformity. The question is what to do with it. Do we correct it acutely? Do we correct it with the frame? Typically we would correct it with the frame. However, this is a CP patient, and CP we know respond very well to acute correction, and they don't do quite well in a frame with their spasticity. So doing x-rays, we can see the severe, the high calcaneal pitch, the Meary's angle as well, so it was 55 degrees in equinus. The anterior distal tibia angle was normal, so nothing in the distal tibia. Meary's angle was plantar by 25 degrees. So if we generate a problem list, so we have an equinus deformity about 55 degrees, you have a transtarsal cavus with a tight plantar fascia, you have forefoot pronation. Additionally, he's a CP patient, this is going to progress as he grows. You have a very tight, so the plan was to do a triceps screw lengthening, Achilles versus gastroc, a plantar fascia release, and maybe a longus to brevis transfer, and then also plus minus an osteotomy, which we needed to do in his case. So what we did for him was first start with an Achilles lengthening, which corrected the equinus, and then we did the open plantar fascia release. Then we had the cavus remaining. So to address the cavus, the plantar fascia release did help us in correcting it. However, it wasn't still satisfactory. So we elected to do a medial cuneiform closing wedge osteotomy, which helped. And then ultimately we did the peroneus longus lengthening, which did help quite a bit as well. So I just saw him last week in clinic. He's doing quite well using an AFO now. But yeah. So postoperatively, for these patients, what I do is weight bearing. So it depends if there's an osteotomy or not. If there's no osteotomy, we do non-weight bearing for 3 weeks, then we start partial, then full at 6 weeks. If there's an osteotomy, we wait until healing, which is typically 6 weeks. We cast them post-op for 3 to 6 weeks and then switch to an AFO. The AFO is for about 6 to 12 months, depending on how much the patient can tolerate it. There's no AFO, we can switch to a cam walker. Thank you.
Thank you, Dr. Abdullah. Any question regarding the case? Yes, Dr. Hatata, please.
Yeah. Yes, equine okay.
There is two components of the deformity here. There is cavus deformity and tight plantar fascia, and there is also equinus with a tight Achilles tendon. If you start with Achilles tenotomy, then the plantar fasciotomy will not work because you need a fulcrum if you will extend the foot. Okay, you will rely on the integrity of the Achilles tendon to resist, and then you correct the cavus deformity. So, in my opinion, you have to start with plantar fascia release first, correct the cavus, and then in the second session, you will do an Achilles tendon lengthening. Thank you.
So
That's why it doesn't work. The plantar fascia release doesn't work.
Yeah, but so why wouldn't it work? Because I opened the plantar, we did an open incision, and we identified the plantar fascia and I cut it. So it's released, right, basically. And I think I did that. I know I said Achilles, actually I did that. I did the plantar fascia first, then Achilles. But even if it was, because I showed this to many of my colleagues, and they had similar to your opinion, and that's why I did plantar fascia first. But for me, if I open and I visualize the plantar fascia, it's released as a structure, right? Yeah. 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 Yeah.
And then you will have some correction of the cavus.
Yeah.
In the second session, after
you mean like a staged operation?
Yeah. Then you can do a correction of the Achilles tightness. Thank you.
Fair enough. Yeah.
So thank you, Dr. Abdullah. Thank you, everybody, for attending today and participation. This was the last session for the day. Thank you.